Welcome back, everyone. We are on page 374, and let's just jump into it. And we have here Pediatrics number 4. It's going to be growth, nutrition, and development. At the top of the page, we have here exam tips on pediatric growth. It says here, birth weight normally doubles by 6 months and triples by 1 year. So if it's a 3 kilogram, he's going to be 6 kilograms when he is in 6 months, and 9 kilograms by 1 year. The height percentile at 2 years of age normally correlates with final adult height percentile. So if we see someone who is in the 95th percentile, really tall, at the age of 2 years, he's probably going to be a tall person. Best indicator for acute malnutrition is weight per height. If it is less than the 5th percentile, weight height less than 5th percentile, I'm sorry. The best indicator for under or overweight is the body mass index. So there are two different things here. The malnutrition, that's going to be the weight height, and it's less than the 5th percentile. And the best indicator for under or overweight, is the body mass index. Skeletal maturity is related to sexual maturity. So less related to the chronologic age. The most common cause of failure to thrive in all age groups is psychological deprivation, which is actually coming as a surprise for me personally. I always thought that the most common cause would be undernutrition, but yeah, who knows. So the most common cause of failure to thrive in all age groups is the psychosocial deprivation. All cases of underfeeding must be reported to Child Protective Services. This is just the law. And finally, you must work up any child who has crossed 2 major growth percentiles. Okay? All right. We have a note here on the side. It says that birth weight is normal in patients with either a genetic short stature or constitutional delay of growth. Patients with either condition have normal growth velocity, which is below and parallel to the normal growth curve. All right. Okay. All right, so we have a table here in front of me, and it's consistent of 3 things. It says of the description of growth pattern, and we're going to see in a decrease in weight gain more than decrease in length and height, normal weight gain and less length and height, and decrease in weight gain equals decrease in length and height. So again, we have decrease in both the weight gain, decrease in weight gain and decrease in length and height, but it is more decrease when it comes to weight gain. He's not gaining weight as much as he should. And normal weight gain, nothing wrong with it, but there is a decrease in length and height, and he has decrease in both weight gain and height, but they are equal to each other. Okay? Okay, and the second column here, it has to do with the differential diagnosis. So what would cause these 3 conditions here? And finally, the workup that we should do in such suspected cases. All right, so the first one is that we're going to have a patient who is losing, who is not gaining weight well, and he's also not increasing in length or height, but he is not gaining weight worse than the decrease in length and height. Okay? So there is going to be a discrepancy where weight is a lot less than length and height. What could be a differential diagnosis for such a case? The first is going to be the undernutrition. The baby is not really feeding as much as he should. And the second is going to be inadequate digestion. Okay, he's getting the food, but he's not really digesting it. And finally, it's going to be malabsorption. So he's digesting it, but he's not really absorbing it. And this could be because of the infection, celiac disease, cystic fibrosis, disaccharide deficiency, protein losing enteropathy, and so on. So again, so he's not eating, undernutrition. He is eating, but he's not really digesting well. And finally, he's digesting, but he's not absorbing. What we're going to do, we're going to assess the caloric intake first, so if he's taking enough or not. The second, we're going to perform a stool study, and that's going to be for fat. And finally, we're going to perform sweat chloride test, and this is for the cystic fibrosis, of course. All right, so really easy stuff, and we can diagnose that patient. Okay, let's say he has a normal weight gain, but he's not really increasing in length or height as much as he should. The first thing that we should talk about here is the growth hormone. So you could not be having enough growth hormone or thyroid hormone. So deficiency of growth and thyroid hormone could be the cause. The second is going to be excessive cortisol secretion, too much cortisol. And finally, it's going to be skeletal dysplasias. So growth hormone and thyroid hormone, excessive cortisol secretion, and skeletal dysplasias. Of course, what we're going to do, we're going to see the growth hormone deficiency here and look for the insulin-like growth factor 1 and the insulin growth factor binding protein 3. Those are two things that we can look for, and they are indicative of the growth hormone level. The second thing is the thyroid hormone. We're going to do a TSH, at least TSH, and then we can do the free T4 and free T3. And if we suspect that there is a Cushing syndrome here or disease because of the excessive cortisol secretion, we can do a 24-hour urinary cortisol, or we can look for free cortisol. And the skeletal dysplasias, we can do a bone age by the X-ray of the hand and wrists, and we can see that skeletal dysplasia, there's going to be no delay in bone age and disproportionate bone length on the exam. Okay? All right. So this is when we have decrease in the length and a normal weight gain. Okay, so how about we have weight gain there is no weight gain, and there is a decrease in length or height, or no increase in weight and height, but equal to each other. So that's different from the other one that we talked about first that had to do with the undernutrition and endocrine digestion and so on, where the weight gain was a lot worse than the length and height. Those are equal here. The differential diagnosis for such case is going to be a systemic illness generally, and the systemic illness could be either a heart failure, it could be inflammation like inflammatory bowel disease or arthritis, it could be renal insufficiency or hepatic insufficiency. So just a systemic illness in general. It could be also a genetic short stature. So he's just a genetic problem that is causing the short stature here. And finally, a constitutional delay in growth and development. What we're going to do for workup here is, of course, we're going to look for the markers for the systemic illnesses here. So we can look for inflammatory markers like C-reactive protein, ESR, CBC with differential, and so on. We can look for the organ dysfunctions, markers like the liver function test, creatinine and BUN. We can look for electrolytes. And finally, we can do a bone age here. In genetic short stature, and we're going to compare that with the skeletal dysplasia here, is that the bone age is close to the chronological age here, okay? And the puberty occurs at the normal time. But here that's different here, because we're going to see here that there is no delay and there is disproportionate bone length on the exam here, okay? So those are two things. The constitutional delay of the growth here, the bone age is delayed. So this is different. And puberty occurs later than in most children. So genetic short stature is different from constitutional delay of growth, is that the bone age in the genetic short stature is going to be close to the chronological age, but in the constitutional delay is going to be delayed. Also, puberty occurs normal time in genetic short stature, delayed in the constitutional delay of growth. Okay? All right, I hope that I did not confuse you in this one. It's kind of confusing a little bit, but it looks like a really important table, and I would advise that you would read it twice at least so you can understand it better. All right, so let's take a look at the second one here, and this is going to be breastfeeding, the second title here. In breastfeeding here, we have advantages of breastfeeding, and we're going to see next the contraindications to breastfeeding here. So the first thing, the advantages, first is going to be a passive. Well, before we actually read this, there is a lot of advantages, but I think those are the most high yield for the exam here. So passive, the first is the passive transfer of T-cell immunity. There's going to be decreased risk of allergies and gastrointestinal respiratory infections, of course, and the psychological and emotional infant-mother bonding stuff. We have a basic science correlate here that we should read, and it has to do with the IgGs, or the immunoglobulins. The immunoglobulin M is going to be secreted during the early stages of humoral immunity. It is the first antibody to be secreted here. The IgG, this causes sustained immunity to pathogens. It is the only immunoglobulin that can cross the placenta. So this is the one that we can suspect that will go from the mother to the child. Lasts about 6 months, I think. IgE, and this binds to allergens and secretes histamine. Of course, we know about that. And the IgA is found in the mucosal areas like intestines, saliva, tears, breast milk, and so on. It is secreted during breastfeeding. And we can see here the look, or the way each Ig is supposed to be. We have IgD, E, and G, and they are monomer. IgA is a dimer, and the IgM is a pentamer. And the monomer, it's kind of small, so the IgG can. That's why it can actually cross the placenta easy. Well, all right. So, anyways, the following point here has to do with the contraindications to breastfeeding. Let's say that the case here would say that the mother has blah blah blah, and one of the options is we should stop feeding that baby because the mother has that condition. So, were you going to choose that option or not? So, let's see what exactly should we do, or when exactly should we stop the breastfeeding here. The first thing is the galactosemia in baby, so we should stop that. And the second is going to be HIV, herpes simplex virus, but if lesions are on the breast. Fourth is going to be acute maternal disease if absent in infant. Let's see, like TB or sepsis. If there is maternal cancer and the mother is receiving treatment. And the substance abuse cases. Oh, somebody would ask, well, what about mastitis? Should we really stop breastfeeding in that? No, it's not really contraindicated in mastitis. So again, we have 6 reasons to stop breastfeeding here. It's going to be galactosemia in the baby. It's going to be HIV, herpes simplex virus, if it is on the breast. A mother is having some breast cancer or maternal cancer in general, receiving treatment. Acute maternal disease if it's not in the baby, like sepsis and TB. And finally, if there is substance abuse. All right. So now we know the contraindications to breastfeeding. Let's move on in the last part, in the growth and development here, and it has to do with the developmental milestones. And those are the high yield ones here. It says that the absence of milestone behavior or persistence of it beyond a given time is significant of CNS dysfunction. Exam questions typically describe an infant or a child's skills and ask for the corresponding age. So sometimes you would say, like, the baby does this and that, and what do you think the baby's age is, and so on. Okay, so we have here a table. Really important one. I think we should be memorizing that table, but I'm going to go through it real quick. It has to do with the age on the left side and the milestone on the right side that corresponds to that age. Okay, so the first one is going to be the newborn reflexes. The newborn reflexes are going to be the Moro reflex, the grasp reflex, the rooting reflex, tonic neck, and the placing reflexes. They appear at birth and disappear at the 4 to 6 months period. The parachute reflex, which is the extension of the arm when fall is simulated, when you have the baby and you cannot simulate that it's falling. This presents at 6 to 8 months and it persists. Okay? All right, so I would highly suggest that you would look for a video on YouTube or anything. I could actually link that down below for the Moro reflex and the other reflexes as well, so you can take a look at those and see for yourself. The next age group is going to be the 9-month, and is going to have the pincer grasp, and creeps and crawls and knows own name. At 12 months, he's gonna be cruises, says one or more words, and plays ball. At 15 months, he's gonna build 3-cube tower, walks alone, makes lines, and scribbles. 18 months, build 4-cube tower. So 15 months, 3 cubes, 18 months, 4-cube tower. Walks downstairs, says 10 words. We began with at least one or more at 12 months, 10 here at 18, and feeds self. So at 1.5 years, he can feed himself or herself. 24 months, 2 years, he builds a 7-cube tower and runs well, goes up and down stairs, jumps with 2 feet, threads shoelaces, handles spoon, says 2 to 3 sentences. I'm not going to repeat all of these again. You should probably just go through it multiple times and try to memorize it. There are, I think, first aid step 1, they had really one of these exact same tables, but I think they were a little bit better. Perhaps in the future we can see better tables in the UWorld. If I see anything, I could actually link it also in the description for a table that would describe those things a little bit better. And again, we stopped at the 24 months. Now next to the 36 months, it's going to be walks downstairs, alternating feet, rides a tricycle, knows age and sex, and understands taken turns. At 48 months, 4 years, hops on 1 foot, throws ball overhead, tells stories, participates in group play. All right, I'm gonna leave that. I'm gonna leave this table here, and as I said, I'm gonna try to link in the description a better table for those milestones so you can memorize it a little bit better. All right. Next, we're gonna look into behavioral disorders. We have a question here. It says a 4-year-old boy has problems with bedwetting. The mother says that during the day he has no problem but is usually wet 6 of 7 mornings. He does not report dysuria or frequency and has not had increased thirst. The mother also says that he is a deep sleeper. Which of the following is the most appropriate next step in management? The first, it says that we give anticholinergics, we give desmopressin, we give prophylactic antibiotics, we perform renal ultrasound, and finally we reassure the mother that bedwetting is normal. All right, well, let's see what the answer here. It says here the answer is E, which is reassure the mother that bedwetting is normal. So bedwetting is normal before the age of 5. So that child, 4 years old, it's a normal problem here. And this is going to be before bladder control is anticipated, and it's fine. So before the age of 5, it is fine. Well, now let's talk about enuresis in general. Well, enuresis is the involuntary voiding of urine, occurring at least twice a week for at least 3 months in children over the age of 5. So if we have somebody who is 4 years old, that's actually still normal. If we have somebody who has at least twice a week, but for just 1 month, it's still not enuresis. If it is once a week for 1 month, it's still not enuresis. And again, over 5 years, when the bladder control is anticipated here. Nocturnal enuresis, which is the nighttime wetting, is more common in boys who are usually continent, occurring within 2 years of the daytime continence. We should really address with the behavioral therapy. Diurnal enuresis, which is daytime wetting, is more common in girls and is associated with a higher rate of urinary tract infections. All right, well, that makes sense. Let's just repeat that again so we can have a comparison here. The nocturnal, which is the nighttime wetting, and the diurnal is the daytime wetting. The nocturnal is more common in boys, and they are usually continent. They occur within 2 years of daytime continence. What we should do is address with behavior therapy. Diurnal, it had to do with the girls associated with high rate of urinary tract infections. So it's probably good to ask for frequency, dysuria, and so on. The most common cause here of the diurnal enuresis is going to be diabetes insipidus. Okay? The second is going to be the UTI, and then seizures, constipation, and finally abuse. So again, the most common cause of diurnal enuresis is diabetes, UTI, seizure, constipation, and abuse. So how are we going to diagnose that? Diagnostic testing, the best initial test is going to be urine analysis, and that's for all patients actually. If signs of infections are present, we're going to do a urine culture. If there is a recurrent UTI, we're going to do a bladder and renal ultrasound, and this is going to be for anatomical abnormalities, or we can do a voiding cystourethrogram. What we're going to treat with, the best initial treatment is behavior and motivational therapy. We're going to limit the liquids, use a bed alarm, never punish the child, and that's going to be cures 2/3 of the patient. If the behavior therapy fails, we can give imipramine and desmopressin, and this is to decrease the volume of urine produced. Okay, desmopressin, I think the antidiuretic hormone, imipramine as the anticholinergic here, and that has been enuresis here. The other one is encopresis. Encopresis is the unintentional or involuntary passage of feces in inappropriate settings, such as into clothing or onto the floor. This is going to be in children older than 4 years, the age by which most children control bowel movements. So over 5 years for the urine and 4 years for the feces. What we're going to do for diagnostic testing, the best initial test is an abdominal X-ray. This distinguishes between retentive, most common associated with constipation and overflow incontinence, and non-retentive, which is associated with abuse. We do not miss uncommon causes. That's really important. Uncommon causes could be like Hirschsprung disease, anal fissure, ulcerative colitis, or spinal cord abnormalities. So it's really important to look for those because they are important. So again, Hirschsprung disease, anal fissure, ulcerative colitis, and spinal cord abnormalities. How are we going to treat that? The best initial therapy is going to be retentive encopresis is going to be disimpaction, stool softeners, and behavior intervention. The non-retentive encopresis is going to be behavior modification alone. All right, and that has been the behavior disorders. I think I'm going to stop at that part. And we're going to have immunizations next. I just thought that we should do immunization in one session alone, and because it's going to take quite some time, and it's really important. All right, so I'll see you next. This has been Pediatrics 4, and see you in the next one. All right, bye.